Welcome, everyone, to a new episode of the Preventive Medicine Podcast. We are back again, and this is actually kind of a re-recording of one that I did, 4 years ago now, I think, when I was a PGY2 resident, and we are back here again. We are with Dr. Chris White today, and we're going to be talking about spinal cord injury, and it's something that we haven't really addressed on these podcasts. And what I like to try to do on this podcast is be pretty inclusive of kind of all of the different populations out there and address preventive medicine really from all angles, because that's what the idea of the podcast is. So today we're going to talk to Dr. Chris White, who will do an introduction for in just a second about kind of spinal cord injury as well as kind of hospital administration to some extent in healthcare, because he has gotten a new role. So Dr. White is a rehabilitation physician at the Medical College of Wisconsin. He is actually the program chair of the pm&R department at the Medical College of Wisconsin. And that's actually huge. That's a pretty big appointment. And he was recently appointed, so he's done a lot of learning. So we get to ask him some questions about that. He's also the former program director for the Spinal Cord Injury Fellowship at MCW. He did his fellowship in spinal cord injury as well as his residency at PMR at the Medical College of Wisconsin. So he's been around a while. He knows a lot of stuff. I'm extremely excited for this episode. So let's get into it.
Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live. And now, here's your host, Raghav Sharma.
We hope you enjoyed the show. And if you do, please don't hesitate to subscribe and like for all of our future content. All right, let's get into it. Dr. White, welcome to the show. I'm so excited to have you. We've been kind of talking about this for a while of making it happen, and it is finally time we're here.
Absolutely. No, thanks for having me. And yeah, thanks for making me commit to doing this again.
So Dr. White's one of the attendings that I had in my residency program that was extremely forthcoming and a great mentor to me. And he is an excellent educator as well. So I'm extremely happy to have him on the podcast. First question for you, and the first question a lot of our listeners probably have, is what is a spinal cord injury? People know what the spinal cord is, but what does it mean to have a spinal cord injury?
Yeah, so great question. And really, it kind of encompasses a lot. And so from a spinal cord injury medicine perspective, when we do our fellowships, we really focus on spinal cord injury, both traumatic and non-traumatic. And so really anything that can happen within the spinal column. And so that can be a motor vehicle collision that causes a subluxation or a movement of the vertebrae and damage to the actual spinal cord. Or it can be lower down in the lumbar region, a big disc herniation that causes cauda equina syndrome, or again, more like a multiple nerves in your back getting pinched. Spinal cord injuries can be complete or incomplete. So when people think about people being paralyzed from the neck down or quadriplegia, not all people with quadriplegia can't move anything below the neck. Some have a little bit of movement in their arms and movement in their legs as well. So they can be complete or incomplete, traumatic, non-traumatic, tumors, vascular issues. So it really spans a lot of topic, but it's a fun place to practice.
Definitely. I know when people think of spinal cord injury kind of out there that don't have too much of a knowledge on the subject, they probably think of people in like their motorized wheelchairs and whatnot driving around. But people don't kind of realize that a lot of simple things can result in spinal cord injuries. They think of like these big traumas, car accidents, all those kinds of things. But if you're an older person and you fall, you kind of hit your neck in the right way or extend it, you can also get a spinal cord injury. So that's things like central cord syndrome. And there's a bunch of things like that. So there's just a huge variety of spinal cord injuries like you're mentioning. What are the kind of the most common ways you've seen that people get spinal cord injuries?
You mentioned one of them again, sort of the older you get when you end up with arthritis, or we call spondylosis in your neck, you get some narrowing of that canal and you can have a spinal stenosis. And so if you fall, you end up with, again, some cord damage. And so central cord, like you mentioned. And then the younger population, it's usually more motor vehicle collisions and violence. So unfortunately, gunshots, car wrecks, those sort of things.
Yeah. And then in that context, you mentioned the words arthritis and whatnot, which is not necessarily preventable for more or less of what we would think about it. So the question kind of comes up. Most people might be thinking, hey, how do I prevent these things? So in that context, what does preventive medicine mean with spinal cord injury?
Yeah, definitely. So when you talk about particularly preventing spinal cord injuries, you think about, again, from a core support. So making sure that you're lifting appropriately, so not putting your spine at risk, making sure that you're moving appropriately, that your biomechanics are appropriate, wearing things like seatbelts. So back in the day when we didn't have cross shoulder straps, there was an increased incidence of people with lumbar spinal cord injuries. And so um, interventions like spinal or like seat belts can certainly minimize or prevent spinal cord injury. Obeying the law, not driving fast, not drinking and driving, making sure that you're, friends with people who maybe are cautious and not asking you to, jump into shallow lakes and that sort of thing. But that's really what it means. That's really the ways that you prevent spinal cord injury. Now, what does it mean to me? I think, again, interventions that can prevent some of the complications of not taking care of yourself. And so from a spinal cord injury perspective, once you have a spinal cord injury, it's trying to prevent some of the complications of spinal cord injury. So preventing things like spasticity or contractures, or trying to manage bowel and bladder appropriately so that you prevent the complications of untreated neurogenic bowel or neurogenic bladder. So, but then from a spinal cord injury perspective as well, our patients are, people as well. And so we try to prevent complications from chronic disease, just like you would in the able-bodied population. So good blood pressure control, diet, exercise to prevent things like strokes and heart attacks, and good weight management and that sort of thing. So I think it's a little bit more complex when you talk about taking care of people with the impairments that I take care of, again, preventing the complications of the spinal cord injury, but also using some of those general concepts of preventative medicine and trying to keep people healthy in general.
Yeah, I just want to expand on one thing you said real quick and potentially have you explain it. So you mentioned things like neurogenic bowel, bladder, spasticity. We do have a relatively educated audience that knows a lot of medical things, but not everything. And when you get a spinal cord injury, pretty much everything below the level of injury can get damaged. So what does that mean in the context of things like neurogenic bowel, bladder, or spasticity? What are those things?
Yeah. So after a spinal cord injury, obviously people are more aware that the motor nerves are damaged, and so it impairs your ability to walk and move. Sensory nerves, so it impairs your ability to feel and sense the world in sort of those usual fashions. But that also then transfers into the bowel, bladder, and sexual function. And so the bowel doesn't work as normal or as it would have prior. And so there's an issue with mobility, or with the motility in the gut. And so people are prone to constipation. And so you use a variety of interventions to make sure that people are able to empty their bowels effectively and efficiently, and so that they can stay clean and participate in the world. Same thing with the bladder. Again, the motor nerves are impaired. And so there's a difficulty squeezing the bladder and relaxing the sphincters to allow yourself to urinate. And so we use some different interventions like intermittent straight catheterization, suprapubic catheters, things like that, to make sure that the bladder stays decompressed and don't put your kidneys at risk of hydronephrosis and damage and that sort of thing. And then spasticity is really a component of the upper motor neuron syndrome, where again, anytime you damage your brain or your spinal cord, you're at risk of the muscles becoming tight. And so tight muscles then can lead to joint contractures and difficulty with mobility and positioning, and predispose you to things like pressure injuries or bed sores. And so really just those are less known complications of spinal cord injury to maybe the layperson, but certainly things that we deal with on an everyday basis in our patients.
You mentioned muscle tightness, and then also people that might not be able to walk, with things like if they have a quadriplegia or even hemiplegia. When we think of kind of exercise, as you mentioned, for preventive medicine, we kind of think of people going for a jog or going to the gym and lifting weights, those kinds of things. So given that a lot of patients with spinal cord injuries are unable to do some of those things, whether they're hemiplegic, quadriplegic, or whatnot, what does exercise look like for spinal cord injury patients? And what are some of the other things that we kind of have to modify, and how do you modify those for spinal cord injury patients?
Yeah, great question. Because again, people with disability and a variety of impairments, we still recommend that they exercise regularly. And so it does look different. So for people with some upper extremity or lower extremity impairment in mobility, again, like you mentioned, they're maybe not going to go for a jog, but if they use a manual wheelchair, then they're propelling with their upper extremities. And so we try to keep people in manual wheelchairs for as long as possible. So you mentioned motorized chairs or power wheelchairs before. We try to use those for the people that really need them, and we try to encourage them to use the muscles and the skills that they have for as long as they can. So again, you can be a manual wheelchair user. That can get your heart rate up. We'll use hand cycles, and so sometimes people who have no lower extremity function will get hand cycles. That can be a hand cycle that you have at home that you put on your dining room table and you try to get your heart rate up. Or again, there are recumbent bikes. There are hand cycles that you can go out and go on the same trails that you could before. You just do it a little bit differently. A huge component of getting people active after spinal cord injury or after disability in general is the adaptive sports world. And so if you can do it with an able-bodied person, you can find a way to do it with someone with impairments. And so I've had patients that have gone, rock climbing that have paraplegia. There are people that go sailing, and we do a lot of stuff with the Paralympics and the National Advantage Wheelchair Games. And again, you play wheelchair softball, wheelchair basketball, wheelchair lacrosse. And so it's about being active, finding community, and just like able-bodied sports, those people are not just participating and competing. They're training. They're going to practices once or twice a week. So you have to be a little bit more creative in how you try to get your cardiovascular health and get your heart rate up. But there are a lot of different ways that we can do that. There's now adaptive CrossFit. So there are people that have motor impairments that are thinking way outside the box and doing a lot of things that we wouldn't have been doing 10 years ago.
I will say one of my favorite kind of learning experiences and moments in residency was experiencing adaptive sports. We were doing coverage for one of the basketball tournaments, and we had spinal cord injured patients playing basketball. Obviously, they're in their wheelchairs, propelling, looks very different than what we think, people dribbling up and down the court. But we had someone who went for a straight up driving layup where they're kind of driving towards the hoop, and then they kind of go for a layup. They got fouled, and they got pushed off their wheelchair. So it was like a huge collision type thing. We're like, whoa. They're still going pretty hard with these things. So it's very different than what many able-bodied people would think about kind of adaptive sports and what that looks like, but they're still going very hard. They're still exercising. And that was a pretty good learning moment for me in residency there.
Oh yeah. Common misconception that, just because you're in a wheelchair that you can't, have some collisions and put yourself into some serious, injury prone positions. I think it's one of the reasons that I absolutely love wheelchair rugby. It's my go-to. And so, if you haven't had the opportunity to watch people play wheelchair rugby, I would encourage you to look that up. Look up some YouTube videos, because it's definitely not for the heart.
Definitely. And then when it comes to diet, that also could look different, because when we think of, once again, able-bodied people, we think of a little bit more mobility, maybe different dietary needs. Is there anything different for spinal cord injury patients that you're thinking of? Is it like more protein for skin breakdown, or are there any unique considerations that you counsel patients on?
Yeah, certainly anybody who has a sore or a wound, we're counseling them on increasing their protein intake to help heal that sore. Otherwise, people with spinal cord injury, both people with paraplegia and quadriplegia, obviously the metabolic rates are different. And so the calorie burn is not maybe as much as it would be otherwise. And so have to make sure that the people are counseled on modifying their diet. And, if you were a, Division I athlete prior and you took in 3,500 or 4,000 calories a day, and now you're moving through the world in a wheelchair, you're going to have to make some of those alterations, just like you or I would have to if we were injured or or whatever. But people with spinal cord injury are at risk of metabolic syndrome, and so we do certainly counsel them on making sure that they're active, making sure that they're burning those calories, and again, just sort of basic dietitian and nutrition, that you have to burn what you put in or you're going to gain weight. And so making sure that we hook them up with dietitians in our rehab unit, and then get them into outpatient nutrition counseling if that's what they need. But otherwise, the diets really are essentially the same. It's, fiber is good, and fruits and vegetables, and, high source protein and that sort of thing, and trying to stay away from processed foods and sugars and that sort of thing. One caveat to diet with people with spinal cord injuries, we mentioned that neurogenic bowel. And so we do have to caution people to watch their diet. And if there are certain things or foods that they eat that maybe make them have an accident, then they need to be aware of that, so that they're not eating that at inopportune times and putting themselves at risk of those embarrassing accidents. But otherwise, you can really eat what you want, just a matter of energy in and energy out.
Yeah, so essentially keep an eye on that Taco Bell run. You might want to time that a little bit better for a bowel program, right?
Absolutely.
Kind of going down the list for preventive medicine type stuff. Next comes up bone health. That's something that we might think of a little bit kind of differently in the spinal cord injury population. For us able-bodied folks, obviously being able to kind of load our bones with things like squats and whatnot, and kind of getting out and doing high impact activities are great for bone health. What does that look like in spinal cord injury patients? Because they're not able to always bear weight as easily, or without assistance at least. So what does that look like?
Yeah, definitely. Very good point. And so, with age, people with spinal cord injury are absolutely prone to the same sort of bone mineral density loss that we would be in the able-bodied population, but it's even to a greater degree. So there's neurogenic osteoporosis or osteopenia. And so the level below the lesion, so if you have quadriplegia, then the areas of the bones below, or paraplegia, the bones below, are at increased risk of bone mineral loss and density loss. And so they're at risk of osteoporosis and osteopenia even more than we would be otherwise from the normal aging process. And so you're right. Also, they aren't always able to bear weight throughout the day and do some of the interventions that we would recommend in the able-bodied population. There are some ways that you can still have people with spinal cord injury stand. And so there are standing frames, or there are now exoskeletons or robotic skeletons that Medicare now actually covers. And so for the right person, they can step into those devices, stand with some assist. And so they get a little bit of weight bearing capacity, helps them stretch their legs, helps them reduce some of their spasticity, can help with sometimes some bladder function, and certainly does give them a little bit of ability to stand and at least bear a little bit of weight. Similarly, again, those standing frames, a lot of times we'll recommend people get those to at least just stand a few times during the day and get a little bit of density on their get a little bit of weight rather on their body. You got to do that carefully, because again, I mentioned they're at risk of osteoporosis or bone mineral loss below the level of their injury. And so the last thing you want them to do is to be prone to long bone fractures or something like that from standing if they haven't stood in several years, or mentioned spasticity, or that muscle tightness that can lead to contracture. Last thing you want to do is put somebody in a standing frame or an electric standing frame and get an exoskeleton and get them to stand if they haven't, had their knees fully extended in 10 or 15 years, or at risk of ligaments and tendon ruptures. And so there's some cautions that we implement, or that we at least counsel, but still the goal is to get them upright and standing. And then medications also. So same medications that you use to treat osteoporosis in the able body, you can use in people with disability with spinal cord injury. But to prevent it, it's really getting them in those standing frames and getting them to at least bear a little bit of weight, even if they're not ambulating.
Yeah. Is there any sort of semblance for like preventive screening DEXAs and all those kinds of things? And then on the topic of DEXAs, is there any other screening measures that you're doing on a regular basis that are different than the kind of regular able-bodied population?
Yeah. So the data is always changing on bone mineral density after spinal cord injury, but I think the majority of us in the spinal cord injury world are at least getting DEXA scans 3 to 6 months after injury. And if the folks are starting to develop that neurogenic osteoporosis, we'll usually then start treating with a medicine, and again, some of those standing interventions, and then recheck again in like 6 months or a year, and then do the same drug holidays that they'll use otherwise in the able-bodied population. Not uncommon for us to send our patients to endocrinology or bone health to make sure that they're getting the right pharmacological interventions. But we would recommend, and we do DEXA scans earlier than you would in the able-bodied population, just because we know that they're again prone to this. As far as other preventative screens, really the preventative task force screens are the same for people with spinal cord injury. So, you screen for prostate cancer, colon cancer, breast cancer, cervical cancer, the same as you would in the able-bodied population. Just looks a little differently in how that happens. Sometimes, again, difficult to maybe get on an exam table, and so have to use some different techniques with the primary care providers and that sort of thing. One of the caveats is if someone has instrumentation in their bladder, is we will yearly recommend kidney screens. So we'll either do kidney ultrasounds, KUBs, or even X-rays or CT scans to look at the kidneys to make sure that they're not developing any kidney stones. Again, after spinal cord injury, you mobilize that calcium, and so that's what leads to some of that bone mineral density loss, but that also increases sometimes the risks of developing kidney stones. And if they develop kidney stones, again, they don't feel as you or I would, and so sometimes those can advance and can be pretty significant before they're discovered. And so trying to prevent those from developing. So yearly CT scans or renal ultrasounds or X-rays to check for stones. And if they have an instrumented bladder, meaning a Foley catheter, then we'll usually have our urology colleagues do cystoscopies where they're looking at the bladder with a camera to make sure that they find any early bladder cancer, because there is an increased risk of bladder cancer with that chronic inflammation of an instrumented bladder. Those are the only ones that come to mind. But otherwise the preventative screens, like you go to your primary care doctor and you're getting fasting labs and you're checking your lipids and you're checking your blood pressure and you're getting your colonoscopies and all those sort of things. Those are at regular intervals.
Yeah, I might be losing my spinal cord injury knowledge slowly. I don't think I remembered much about the bladder or the kidney screenings. Kind of in addition to that, this isn't on the outline, but I thought of it kind of right now. As far as additional screenings that we might not think of, is there anything for mental health out there? Because obviously it's a huge change in someone's kind of daily life in all regards. And that can have an impact on mental health. Obviously, being and working with spinal cord injury patients during residency, I see the effects of that. Are there any sort of screenings with that regard?
There aren't any necessarily recommended screenings. I would say that most institutions that do take care of people with spinal cord injury and have the multidisciplinary type center that we do, we certainly incorporate it into our practice. We're seeing our persons with spinal cord injury at least every year. And we will, as a part of our review of systems, ask them about, social determinants of health and if they're feeling happy and well, and if they feel supported at home, and if they have access to appropriate food sources and those sort of things. So the providers are sort of going through that checklist. And then we do have rehab psychologists on staff that if someone is having issues with adjusting or that sort of thing, we'll send a referral to them. But as far as special screens, not really. Primary care does a depression screen at their visits. And so they would, if they go for their primary care visit, they would get that typical depression screen, but nothing specific to people with spinal cord injury.
And then the last thing kind of on that same topic is one of the things that we've stressed as kind of a pillar of preventive medicine is a sense of community or sense of belonging, sense of purpose, those kinds of things. And that can obviously also change quite a bit when it comes to spinal cord injury. I've seen it mostly in the veteran population with things like Paralyzed Veterans of America and a variety of different organizations that foster a sense of community. But kind of for the general public out there, what does that community look like? And what does engagement look like for these patients now?
Yeah, I think great question, and absolutely community engagement and getting our patients and people with spinal cord injury back out into the community is a pillar of what we do as rehab physicians focusing in this area. And so it's, again, a lot of it is, that adaptive sport is what comes to mind. Again, it's teaching them that there are still ways to be active in community despite moving in a chair and despite, the world looking a little bit differently. So community and community sports. A lot of the adaptive sports programs, you can imagine, at least, different parts of the country anyway, there might not be enough people that are wheelchair users to actually populate a team. And so sometimes they'll call for able-bodied folks to come in and join. And so there's also that sense of community there, which has been invaluable. I've had, I've been in some of those sporting events and have participated, and have obviously recommended a lot of medical students and residents get involved as well. And so there's something to be said about putting yourself into that situation and learning from the stakeholders, so to speak. And again, we who don't have disabilities don't have all the answers for people that do. And so talking to them, making sure that we're getting their thoughts are certainly important. And so that's part of building that community, is making sure that we're integrating with one another, and then it's not just people that are wheelchair users participating in communities separately from those of us who aren't wheelchair users. So I think that's a huge it's a benefit to both groups. So, and otherwise, there's all sort of, federal laws that protect people with disability. And so the whole idea, at least in this country, is to reintegrate folks back into society. And so what, again, I tell all of my patients is again, what you could do before, you can do now, just might look a little bit differently. Again, you can get a job, you can go to school. I've taken care of plenty of people who end up, going and advancing their degrees. And, one of my patients became a physician. And so it's really just making sure that we're doing our part to to get them in contact with those resources, and that we're doing our part in engaging our community and building these programs. So in Wisconsin, we're lucky. We've got what's called the Wisconsin Adaptive Sports Association, the Medical College of Wisconsin. One of the pillars of our institution is community engagement. So we're constantly looking for ways to make sure that we're being good stewards and good citizens in our community to help build those programs.
And I will say, when it comes to volunteerism, if there's ever like medical students listening to this or residents, or any advice that I give, if anyone's interested in physical medicine rehab, or even if anyone's looking for anything interesting or meaningful to volunteer in, this is a great kind of place to put your effort and time in. You can understand kind of a different type of patient population and how people go about their lives, even though they might have different kind of anatomy than us or different kind of physiology at that point with spinal cord injury. It's just a great way to understand something that's different than us sometimes as able-bodied folks. If you are listening to this, you want something meaningful to volunteer and do, then this is a great spot. As we're starting to transition away from the spinal cord portion of this podcast to a little bit more of the administration portion, the last question I have for you is, let's say you have like 2 minutes, you're in an elevator, spinal cord injury patient in there, just ask you, hey, you're Dr. White, right? You're world famous for spinal cord injury. How do I get healthy? What do you tell them?
A lot of what we talked about here, again, finding something that you love. I think, again, all of us who have been through various exercise programs, it comes and goes unless you love it. So find what you love. If that's swimming, then get back to swimming. If that's riding a bike, then get back on a bike. So find something that you find enjoyable, that gets your heart rate up and gets you outside or around other people, and do it. And make sure that you are understanding the whole energy balance of your body, that energy in has to equal energy out, or you are going to gain some weight. And make regular appointments with your doctor. Like it's important for all of us, but it's exceptionally important for people that are going through some complex changes like those after a spinal cord injury. So go to the doctor regularly, eat well, know the energy balance, and then find something that makes you happy and do it with others.
Yeah, I think one of the biggest driving home points then for those who are listening is life looks a little bit different, but that doesn't mean it changes all that much. You can still engage in a lot of things that you were beforehand. You just have to be a little bit more careful about some things and be a little bit more connected to healthcare than you might otherwise be. But as we kind of wrap up that spinal cord injury portion, the other portion I really want to talk to you about is kind of the healthcare leadership administration portion, because you recently got promoted to program chair. So congrats on this podcast from the Preventive Medicine podcast behalf to you. Obviously, that comes with a whole bunch of new responsibilities. So kind of what have you learned, or first off, for those who are listening who don't know how kind of academics works, what is a program chair? And then after that, what have you learned about the healthcare system from your new role?
Yeah, great question. And now I see we're moving into the not so fun stuff. But, no, I appreciate the congratulations. Thank you. So in an academic department, we have what are called department chairs, and so the department chairs head up the academic missions of each of the clinical departments. And so the institution that I work at the Medical College of Wisconsin, we have 4 missions: clinical care delivery, education, research, and community engagement. And so my job as the department chair of pm&R at the Medical College of Wisconsin is to help lead those ventures and to make sure that the Department of pm&R is adequately resourced and staffed and is able to participate in those tasks. And so it looks different in different venues. Again, so if you take the education space, then I've got a crew behind me: program directors, program leaders, associate program directors, program coordinators. They work in the department as well, that sort of take that mission and run with it. And I am there to, again, help guide and direct and give them a little bit of guidance as to where I see the department going, and again, then to help it be resourced. So it's a lot of budgeting, and it's a lot of HR and people management, change management that maybe most of us physicians didn't sign up for in the beginning.
The fun stuff, huh?
Yeah, it's been gratifying. So I've been doing it for 9 months, and yeah, it's fun. It's fun.
So as a program chair, obviously it looks different in academic centers versus private practice at kind of different levels. But from your kind of standpoint, what has been kind of the biggest revelations that you didn't know before you were promoted to program chair about the healthcare system, hospital systems, academics, all that kind of stuff?
Yeah, so I think a lot of it, thankfully, I'd had a little bit of exposure to just in some other aspects and positions. But I think one of the things that's just been elucidated more and more is just the complexity of the healthcare system in the United States. Um, at my level within the department chair level, I'm not negotiating with insurance companies and payers and that sort of thing, but we have certainly a lot of people in the practice and hospital system that are responsible for that. And those changes are meaningful and they matter, and they impact the amount of money that departments and institutions and hospitals are able to bring in. And so it really, it's been interesting to be on this side of things and to see just the importance of those contractual obligations with payer sources and how even a little bit of fluctuation in the macroeconomics of healthcare in the United States impacts a department like ours. If the government and the country is going through change and less people are insured or more people are insured, or the type of insurance that they have changes, it can really impact the care that we're able to deliver. Again, everybody has heard about peer-to-peers and prior auths and those sort of things. And so, if all of a sudden insurance companies decide that they're not going to pay for a certain drug, and that's been a huge part of your practice, then you've got to adjust. Or conversely, like I mentioned earlier, if Medicare all of a sudden decides that standing frames and exoskeletons are approved, then you've got to stay on top of your game. So I think it's just one of the eye-opening experiences in the last 9 months has just been the intricacy and how many people there are behind the scenes making this work and trying to make sure that our institution and our practice is able to provide the best care possible to the people in Southeast Wisconsin.
Are those changes in policy and kind of how payers are working, what they're approving, what they're not approving, is that something you have to actually be aware of from yourself, or is that people on the back end kind of keeping an eye on things and passing it down to the department? And if those do change, let's say the department is like heavily, not saying MCW pm&R is, but let's say they're heavily relying on exosuits, let's say, and all of a sudden those are not approved, and let's say they were approved before. How does that practically change the department and things? Does the entire department just quickly pivot, or what does that look like for the patients that were reliant on these things?
Yeah. I think not talking about MCW specifically, or again, our practice, but yes, like if a payer decides to stop paying for something that they've been used to paying for. So if we look at, again, we mentioned spasticity and botulinum toxin injections are one of the ways that we treat that. And so if insurance companies all of a sudden decide that we're not going to allow botulinum toxin to treat post-stroke or post-spinal cord injury spasticity, then yeah, the department and the institutions and the hospitals that not just ours, but that across the nation that are used to providing these services for people then do have to pivot and change. And it's not something that each department or each institution can absorb on their own. It's sort of, the money dictates sort of where the procedures can happen and how they can happen. And so it is something that I have to be aware of at the micro level within our department. I've got to stay up to date with sort of what changes are coming down the line. I am lucky that I work at a large institution, so there are a lot of people behind the scenes that are usually helping to sort of pass down some of those changes fairly quickly. Working in private practice, if people decide to do that and it's solely on their plate, I can imagine how stressful that would be. So certainly lucky that in large institutions, both academic and private, there are a whole bunch of people behind the scenes that are making sure that we understand what changes are coming.
Speaking of people behind the scenes, a lot of times people and patients don't really understand how a hospital works, what the leadership levels look like, whether it's, I guess most patients typically go to large hospital systems. They're the largest kind of employers in a lot of states, all those different kinds of things. What does hospital leadership actually look like? What are the different levels? Who's actually making decisions? Is it like a collaborative effort? Is just one guy at the top saying, hey, we're doing this month? What does that look like?
Yeah, great question. And again, like you mentioned, it does sort of change depending on what type of a practice or what type of a hospital you're going to. So again, if you're at the VA hospital, then obviously the guy at the top is the president and the Secretary of Health and Human Services and the Secretary of the VA. Those are the ones that sort of help dictate policy. Although the Secretary of Health and Human Services at the government level can certainly dictate, what Medicare covers and don't cover. What are the recommendations from a government perspective? So I would say at the very top of the bureaucracy, bureaucracy. Again, we have to make sure that we're aware that there certainly are people in the government that can impact those choices. Now, at the hospital level, it really depends whether you're in a small community hospital, or whether you're in a large academic center or a large private institution. So at our institution, and most of them around, there's usually a governing board, and then there's usually a president of the hospital. And so the president answers to the board. And then under the president usually has a whole bunch of vice presidents: vice president of clinical affairs, vice president of operations, vice president of finance, whatever the case may be. And so a whole bunch of vice presidents that are running the sort of business of the hospital. And then there's usually a second set of leaders that are, again, more in the medical domain. So a chief medical officer, some associate chief medical officers that are, again, responsible for the actual care delivery, making the decisions as to what's appropriate, what's not appropriate, how to keep patients safe, how to deliver the care effectively and efficiently. And then it just trickles down after the chief medical officers and the associate medical officers. Then you've got medical directors of clinics, medical directors of units that are, again, at that more local level delivering the care. So that's kind of the bureaucracy and the structure of most hospital systems. And again, there's huge hospital systems now in the United States. So if you think of, Kaiser Permanente, there's a board. There's a president of Kaiser Permanente, and then there's regional presidents and regional vice presidents. And so it really can get pretty complex. And so to answer the question, is there a sort of a person at the top just saying this is how we're going to do it? Not often. It's usually a collaborative decision that's made through a variety of different channels. And again, like I said, there's usually a board, and then the presidents and vice presidents that are at least making those business decisions. But from a pure care delivery standpoint, again, on the physician side of things, usually a little, I won't say simple, it makes it sound like it's just easy, because it's not easy, but there usually are, there's like the medical officer that's helping to make the decision in the hospital, and sort of is the one stop, buck stops with me sort of person. But it can get complicated. And then what I would say, just anecdotally, and this is, again, my opinion, this is not reflective of anybody that I work for or whatever, but the bureaucracy of medicine has definitely grown over the last 15 to 20 years. And so I think people on your podcast have probably seen the graphs of the physician employment has remained pretty stable, but the amount of bureaucracy and the amount of business people that are hired behind the scenes in medicine has certainly skyrocketed. Part of that is, again, because medicine is more complex than it was 20 or 30 years ago. And so that it takes a lot of those people, like we just talked about, to negotiate insurance contracts and make sure that billing is appropriate and optimized so that you can recoup as much money as you can from payers, and that you're not you don't dot your I so you don't get these $10 or whatever. And so it's definitely much more bureaucratic than it was 20 or 30 years ago.
Now, feel free to answer this however you want to, but as far as the bureaucracy of medicine goes and whatnot, it sounds like physicians are kind of a stable population. We're here to help people. Obviously, our incentive for the most part is to help people. But when it comes to kind of these large hospital systems, whether it's like a regional hospital system or something like Kaiser, which has hospitals all over the place, what incentives do they actually have to deliver better care to their community? Because from kind of the patient perspective, everyone just thinks, hey, I'm going to go to the hospital. They're here for me. They're going to help me get better. But obviously, that's not the whole picture. What do all those incentives look like from your perspective?
Yeah, I think that's a good question. I do agree with you. I like to think that, again, most of the people who went into medicine from a physician, provider, APP, nurse practitioner perspective all did it because we want to help people. And so ideally, again, if you didn't, then I'm not sure why you're still doing this. Ways that you can make a lot more money and have a lot less stress than healthcare these days. So I think that's number one, is the people at the core are there to care. We're there to make the decisions that best benefit our patients. As far as incentive wise, there are a lot of different changes that are taking place in the landscape of medicine these days. Bundled payments, metrics. So, healthcare metrics that, just use readmissions, for instance, that, the payers and the payer models are incentivizing people that provide quality care. So if your hospital discharges patients from the hospital and they stay home 1 or 2 days and then they're back in the hospital, again, we track those sort of metrics. And so both from a government payer source and from a private payer source, the more of those quality metrics that you meet, the better the care that you provide, then usually the more incentive that the higher the pay rates, so to speak, are. And so there are a lot of things coming down the line, from a PM&R perspective. There are a lot of movements for bundled care and bundled payment. There's some stuff that's starting off in the East Coast, where even like joint replacements, it's a matter of, payers are starting with these ideas of, this is your bundled payment for a knee replacement. Do with it what you will. If that's outpatient therapy, if that's inpatient therapy, whatever. But when the money's gone, the money's gone. And so again, I think we've got to pay attention to that. And if you really do what's best for the patient, make the decisions based on what's best for the patient, take good care of the patient, and make sure that you're trying to, again, keep them happy and healthy and out of the hospital, then I think that bodes well for any sort of incentive plans or payment models that change in the future. But number one is be a good person, be altruistic, adhere to that Hippocratic oath, and first do no harm. And again, just make sure you're doing what's right for the person and the patient first.
Yeah, we're all here for the patients. But I guess when patients go to different providers or different hospital systems, it's sometimes difficult to choose, where do I go, unless there's one player in town and they're like, hey, I have to go here. But if there's several systems in town, there might be slightly different incentives. And you keep mentioning, or you've mentioned several times, the 4 kind of pillars of MCW. How do those kind of incentives trickle down to things like the mission, and how do hospitals differentiate themselves? Let's say, why would I go seek care at MCW versus another hospital that's in Milwaukee?
Yeah, I think that's a good question. I think a lot of hospital systems are trying to figure that out. What I would say is just, and this is generally speaking, again, not reflective of where I work or where we've trained in some of the academic centers in Chicagoland. And me, I did my undergrad or my medical school in the University of Oklahoma. But the academic health centers do typically have a reputation for taking care of the sickest of the sick and for taking care of kind of the most complex cases. Those usually are the locations that have the highest density of specialists and subspecialists. And so, if you need a liver transplant, you're not going to get that at a community hospital. If you need a surgeon who, takes out complex spine tumors, you're not going to get that at just any hospital. So I think a lot of hospital systems differentiate themselves with the programs that they put their resources behind, whether that's, again, cardiovascular or cancer or neurosciences or whatever. And so I think a lot of hospital systems and even private practices are trying to differentiate themselves. And I think if everybody in medicine focuses on the patient first, that's a good place to start. And so whether you're spending millions on marketing and then providing terrible care, probably not a good model. Probably not going to recoup those millions. If you're not spending millions, but you take good care of patients, you get good reviews, word on the street is that you've got competent, compassionate providers that really care, people are going to want to come see you. And so I think, again, we as physicians need to take the lead there and, again, provide compassionate care, listen to patients when they're trying to tell us their problem and their story, and focus on that. But yeah, I think definitely, to your point, there's a lot of market differentiators, and whether it's academic or whether it's program growth, again, being a good citizen in your part of the state or country where you're practicing is important. And I think, again, just making sure that you're a face for your institution. Talk about this a lot with residents and trainees, and even when we're interviewing, but like part of being a physician or a provider in general these days is maintaining a sense of high professionalism. And so if you're professional, if you treat people with respect, if you're an upstanding citizen, if you are an active member in your city and state, and again, you're a face, then you make that reputation, and you're going to gain that following, whether you're independent or whether you're in an academic practice or private practice or whatever.
For sure. You mentioned growth of hospital systems and whatnot, and obviously healthcare spending is still growing, and hospital systems are still growing as employers. It's kind of all a bunch of different things, a bunch of different ways healthcare is growing, some good, some bad. How do you envision the future of healthcare progressing, let's say in the next 10 years, and then after that, in the next 50 years? We might not be around for those 50 years, but what do you see happening that kind of down the pipeline now from your kind of little higher position than me as a measly fellow here?
Yeah, well, I would say I'm not going to be there in 50 years. You can give it a go. I think in the next 10 years, a lot's going to change. I think, again, as the cost of healthcare continues to rise, and as we have these debates on coverage and insurance and otherwise, and is healthcare a right. And I think the rest of the world has settled that question. Again, I'll keep my personal beliefs out of this, but I think we as a society have to decide where we land on that issue. And so I think it's coming. I think it's coming because, as you mentioned, the healthcare cost continues to rise. There's going to become a point where it's just not feasible to continue to do it the way that we're doing it. I think there are a lot of unique ideas. And I think if we use one of these examples, not to sort of talk about any specific, endorsement, this is certainly not an endorsement, but the simple things like entrepreneurs doing things like Mark Cuban has done with, cost plus drugs, finding ways like that to partner with private institutions and private firms that are making things more affordable. I think that's what we're gonna probably start finding, is that there are ways that we're going to think outside the box, different ways that we're going to try to find coverage for folks, have the debates about what should be covered, what shouldn't be covered. But there's no doubt, I think all of us in medicine would agree that the costs continue to rise, and sometimes the outcomes aren't necessarily following with that investment. And so something's going to have to give. So the next 10 years, I think AI, I think a lot of people are
There's that word.
I think a lot of people are scared of AI, but I think the writing is on the wall. It's going to change the way that we deliver healthcare. And I think physicians need to recognize that and be at the forefront of that change. It's already changing the way that insurance companies are evaluating their claims. Like they're using AI to pick out words and deny claims and whatever. And so I think we as physicians need to just recognize that that's not coming, it's here. And again, the way that we deliver care is also going to be impacted by AI. And I think embrace it, make us more efficient, make us let it help us with documentation, so that we can be more efficient and again can spend that time with the patients that patients are wanting. I think those are probably the next 10 years. The pay sources, the model are probably going to change again, just like they did 10 to 15 years ago. And I think AI, and it's going to be much more resource driven. In the next 50 years, I think maybe we'll,
take a shot in the dark there. That 50 years could be anything.
Genomics and big data and precision medicine. Maybe eventually you're going to be like, born, you're going to prick your finger. You're going to say, hey, Raghav, in 75 years, you're going to get lung cancer, but we're going to, knock out this gene and you're going to live to be 400 years old now. So not really, but
I don't know if I want to be 400.
I think that's probably where it's going to happen, where things are going to change the most is precision medicine. I think we're probably not going to be prescribing medicines the way that we do now. We're probably going to be having a personal profile on a patient, and we're going to know that an ARB works better for you than an ACE inhibitor, or for your heart failure, you need this drug, not that drug, or you're going to be a type 1 diabetic and you need this, but not this. I think, again, it's going to be much more precision driven. And so we're already headed in that direction. Hopefully that'll be honed in the next 50 years. But other than that, maybe people just won't get sick. Maybe your podcasts are going to get people off the couch and, active, and we're going to do away with obesity and heart disease and all of those things. So.
Yeah, in the next 50 years, preventive medicine will have taken off, and we will have much less burden of disease. So we can hope. And I think we both know a physician from my residency class that might be at the charge of big data and AI in medicine.
Yeah.
But two other anecdotes as far as AI goes. I definitely do think that it can help physicians quite a bit as far as documentation goes. Just simply being able to spend more time with patients and not worrying about kind of charting and whatnot. We can have kind of AI models helping with that. And then the other kind of anecdote and kind of a personal plug. So if you're listening to this podcast, the previous, I think either just the last episode or the one before that, I did kind of my version of a breakdown of a healthcare system. So obviously I don't want to force Dr. White into saying some things he might not want to, or having him hedge a lot. So if you're interested in kind of the healthcare system and a little bit more in some of those incentives, you can dive into that episode. It'll be linked in the show notes below. But that's kind of all that I had planned for you, Dr. White. Like I said, I don't want to force you into saying anything that you didn't want to, but I appreciate you coming on for your time, for your expertise in spinal cord injury, and as your kind of position as a program chair now.
Yeah, happy to do it, and I'll be happy to share some of my thoughts off the record so that I don't jeopardize my
But, and I know you're not really huge on social media, but is there anything that you want to kind of highlight, plug, shout out that we can put in the show notes as well, or that our listeners can kind of check out?
No, I mean, definitely, I am on X, formerly known as Twitter, and I do have an Instagram, so certainly you can follow those. And if anybody wants to reach out and ask questions, be happy to answer. But yeah, pleasure reconnecting.
All right. Appreciate it. Take care.
You too. See ya.